Our next presentation is by Dr. Alan Cruess, who is a retina specialist. It's good timing to put your talk after mine, Alan. Head of the Department of Ophthalmology in Halifax, which is in the eastern coast of Canada. He is the recent past president of the Canadian Ophthalmological Society. He's also a member of the Scientific Advisory Board of the AMD Alliance International. His talk will address the economic burden of bilateral neovascular age-related macular degeneration, a multi-country observational study.
Thanks very much, Mary Lou, and thank you for helping to organize and chair this symposium and for the invitation to speak here today. My talk really brings coals to Newcastle in this audience, I'm sure, and will be the sort of data underpinning the points that were made by both Mary Lou and by Dr. Cortez from Lighthouse. There is, notwithstanding some of the previous claims you've heard, when this study was initiated with the Pfizer Outcomes Group, there was limited research examining healthcare costs of neovascular AMD, and this was constraining a full understanding of the economic impact of the disorder. And we all know, you've heard, that we have increasing aged populations in Western countries, and that this will necessitate decision makers grappling with payment issues for new therapies, but also understanding the burden of this illness. You all have had a great introduction to neovascular AMD by Dr. Hageman and Dr. Maberly, so I won't dwell on that. But the purpose of this study was to characterize and quantify both the humanistic and economic burden of illness in AMD patients compared to elderly controls. There were three hypotheses. One was that visual impairment compromises an individual's independence and quality of life, and as you've heard, Mary Lou lives with this every day. That central vision loss impacts visual functioning with reading, writing, walking, discriminating colors, driving, and so on, and that AMD is associated with anxiety, depression, falls and fractures, dependency on caregivers, and higher resource utilization. This was a 5-country study in Canada, France, Germany, Spain, and the United Kingdom, and it was a cross-sectional observational case control study conducted in these 5 countries. And what was interesting is, as you'll see, it gave insight into our different health systems and how we pay for direct medical costs differently in different countries, as well as how our social infrastructure is affected. The study sample took patients with subfoveal bilateral neovascular AMD, and these were recruited from retina specialists' offices and clinics both across Canada and in the countries mentioned, compared with controls enrolled from general practitioners' offices and clinics in the participating center cities. And the humanistic outcomes which were examined were the VFQ-25, the Visual Functioning Questionnaire that was developed by Carol Mangione and the National Eye Institute, quality of life measured using the Euroqual EQ5D score, as well as a mental health score, the so-called HADS score, which is an anxiety and depression scale, as well as economic outcomes, which included AMD diagnosis and treatment, vision-related falls and injuries, treatment of psychiatric illness, low vision services, and assisted living services, as well as social welfare benefits. The AMD cases and controls, it shows you that there was a little bit of a difference. The average age of onset of wet AMD is in the mid-70s, and the controls were sort of mid-60s, which might bias the results considerably, but that's really the only major point to make here. And footnotes to the baseline data, however, was that we did subgroup analysis and conducted in control patients more than 70 years of age, and to determine the impact on age on study outcome, and we didn't find any impact. So we were concerned about that difference in age, but we didn't find any impact when this was analyzed statistically. We know that AMD presents late and progresses rapidly, and in terms of actual acute care results, this is a major impact. We've got all these new therapies coming online and more exciting ones to come, as Greg alluded to, but we're getting patients, especially in our country, too late and we're not seeing the outcomes that the clinical trials would herald. So that the average age, for instance, of the first eye diagnosis, the average visual acuity is 2100, and there are only months for vision to progress from diagnosis to 2200 or worse, so-called legal blindness. If patients are diagnosed with wet AMD, they have an average life expectancy of 11 years, and this is pretty consistent across all of the countries. And you can see the blue bars, I guess I would go back. The blue bars were first eye diagnosed average age, and the red bars were for the second eye diagnosed average age. So you can see they're a little older. And here are the sort of top line data. You can see that in all the areas, in the vision functioning, in the vision quality of life scores, there is a highly statistically significant difference between the AMD group and control group, and as well as in the health, mental health status, as well as in the general quality of life scores. So this is the data that really underpins our previous two speakers' claims. And looking at age-matched results, again, you can see the adjusted NEI VFQ summary scores showing the statistically how these are statistically significantly different. And this is another way to look at the data. This is the primary outcome measure with the NEI VFQ 25, with the control group on the right and the AMD group in yellow, showing the statistically significant lower score for NEI VFQ 25. AMD patients had a significant higher rate of falls and fall-related fractures and treatments, and you can see that they're pretty much double. And so this is data that really underpins an important point, because not only when we tot up the costs, are we totting up costs related to AMD care, we're also totting them up for all of the other comorbidities, and the knock-on effect is massive in our health systems. And AMD patients obviously require significantly more assistance, but what I think is more interesting about this slide is the fact that we actually have too low a number with respect to the number of people getting to vision rehab. And so here it is for people requiring low vision rehab benefits and social benefits. You can see that really only a few patients, 35% of patients were getting referred, 43% of patients. It should be closer to 80 or 90, presumably. Probably Mary Lou would say 100 should be referred to low vision rehab facilities. AMD patients had substantially higher annual health-related costs, and you can see here these are highly statistically significant differences, and you can see the different costs in US dollars from the various countries surveyed. There was no significant difference, however, this is an important one, in annual costs between unilateral and bilateral AMD patients. So this shows the importance of the AMD Alliance's rejection of the initial NICE position, which was that we'll wait till the second eye gets affected before we'll pay for treatment. This study gives data to support the reversal of the NICE decision. Economic burden of AMD. The AMD cost to society, you can see the direct medical costs include the listed group. The direct non-medical costs include home care, visits, caregiver, formal and informal, and social services, and indirect costs such as work absences and so on. And you can see this slide gives really an insight into the differences in our health systems. You can see Canada, this was really done during the Visudyne era, and Canada was doing a good job, really equal to Spain in terms of paying for Visudyne for its patients in need. Whereas you can see how much better Germany does with respect to the social benefits for visually impaired patients versus Canada. So we really do have a two-tier healthcare system if one includes the entire spectrum of care, notwithstanding what some of our politicians would like to claim. If you look at the annual costs, these are probably underestimated, but you can see in Canada our annual costs for AMD approach $1 billion a year. So in discussion then, this is really one of the first population-based studies to report health resource utilization by patients with neovascular AMD. giving insight into main cost drivers associated with AMD, including medical expenses for comorbidities and activities of daily living, as well as assistive devices. And in conclusion, therefore, bilateral neovascular AMD has a substantial impact on patients' quality of life, resulting in increased health resource utilization as well as societal costs. That this disease burden and disability contributes to increased societal costs, and earlier intervention with novel new therapies will be a prudent health investment in the 5 countries surveyed. And I'd like to acknowledge the PIs in the various countries, including Giselle Subran in France, Daniel Polyakov in Germany, Jordi Moniz in Spain, and Andrew Lottery in Britain. And also particular attention should be paid to Gerganas Lateva, who was a PhD outcomes researcher for Pfizer. Thank you very much.